Hello, I'm Craig Walker. I'd like to welcome you to this program, which tonight is being sponsored via an educational grant from Janssen. And indeed, it's my pleasure to introduce you and to introduce our moderators who will also be speaking tonight, Dr. Fadi Saab and Dr. Richard Neville, neither of whom really needs any introduction. You know, all of us at this meeting and all of us involved in peripheral vascular treatment want what's best for our patients. But it is not a magic pill in terms of a wire or a procedure that does everything. Certainly, pharmaceuticals play a major role in what we can achieve with patients. Now, we have learning objectives for tonight's session. These learning objectives are the following: to assess the efficacy of factor Xa anticoagulation in combination with aspirin to prevent major adverse limb events, or MALE; to analyze efficacy and safety findings from clinical trials of factor Xa anticoagulants in peripheral arterial disease; and finally, to determine which PAD patients might be optimal candidates for therapy with low-dose factor A anticoagulation plus heparin. So with that, it's indeed my pleasure to introduce our first speaker, a great friend, one of the real phenomenal young minds in this space, Dr. Fadi Saab, who's going to speak to us on the role of factor A anticoagulation in critical limb ischemia.
Well, thank you, Dr. Walker, and it's my distinct pleasure to be sharing the stage with two of the giants in the field. So I'm humbled and grateful at the same time. So I'm gonna, data and antiplatelet therapy, anticoagulation therapy is not the most dynamic conversation that you want to have, but at the same time it's a very important topic that we're faced with on daily basis, on hourly basis, quite frankly, when you're doing this kind of work. These are my disclosures. So just a little bit of information, and I think everybody has been exposed to this. We know that identifying patients with PAD is important because there's an increased risk for those patients to have cardiovascular events, especially even if they have asymptomatic disease. And at 5 years, 1 out of 5 patients with PAD will experience an unfatal cardiovascular event, and it's a cardiovascular event. So 15 to 20% of patients will die, and mostly from cardiovascular events. So just to highlight that, it's a deadly disease. And it's nice that we're always talking about what it can do, but this is what this evening is about. Is there a glimpse of hope at the end of that tunnel that we can start to do something about it? Most PV patients fall in 3 groups. They're either symptomatic, but the reality is most of them are asymptomatic or they have atypical symptoms. And the story with CLI patients is extremely grim because a lot of those patients will die from a cardiovascular event or will have a limb amputation. So just give you a perspective, a lot of the meetings have been criticized for just talking about revascularization or technical aspects, but all of the physicians here that perform these procedures, surgical, endovascular, whatever type of procedure you perform, we're also very interested in the medical therapy aspect for those patients, because there is definitely a signal that treating patients helps. So this is an older trial between 1999 and 2004, published in 2011. But it saw that not a lot of patients are on appropriate medical therapy. 30% of patients with peripheral vascular disease were on statins. About 24% of those patients were on ACE inhibitor or angiotensin receptor blockers. And not even a lot of them were on aspirin, something that, a lot of the physicians that attend the amputation prevention symposium will be appalled by. And among patients with PAD and no other cardiovascular event, the use of multiple preventive therapies was associated with a significant decrease in adverse events. All right, so let's tackle some of these treatments. So if you look at aspirin, for example, some recent trials, like the POPAT trial and the AAA trial, looked at the treatment with aspirin in patients at low risk. And those patients have relatively marginal ABIs. And unfortunately, the results showed that treatment with aspirin was not necessarily beneficial for those patients. And if you look at a meta-analysis looking at 18 trials, patients that were taking aspirin monotherapy, there was a non-significant reduction in cardiovascular events. The absolute event rate was about 8.2% versus 9.6%. However, there was a significant reduction in non-fatal stroke, and based on a lot of these trials, the guidelines suggested that taking aspirin will be a class 1 indication, level of evidence A, among patients that have symptomatic peripheral arterial disease, and it's level 2A, meaning it's a good idea, for patients that have asymptomatic PAD. Well, how about clopidogrel? Clopidogrel is indicated as an alternative to aspirin for antiplatelet therapy among patients with PAD. However, recent studies suggest that less than 20% of patients with PAD are prescribed clopidogrel in clinical practice. And I will tell you that as cardiologists that have patients with coronary artery disease and they have stents in their coronaries, we struggle a little bit switching patients from one drug to the other. We don't know. The Capri trial looked at the use of clopidogrel as a primary therapy for patients, and it was associated with a small benefit in comparison to aspirin. And there was about 23.8% relative risk reduction, but it's when I was a research fellow, I always thought that relative risk reduction is a really nice way of inflating things, because in reality, if you look at the absolute rates of outcomes, it was 3.7 versus 4.9%, about 1% difference between both groups. Not to minimize the importance of it, but it's always interesting to look at relative risk reduction. Well, how about combination therapy? If you look at dual antiplatelet therapy, 75 to 162 milligrams of aspirin with clopidogrel, Charisma trial is an old cardiology trial that always been coded, looking at clopidogrel for high atherothrombotic risk and ischemic stabilization management. It found that the overall results of the trial were not significant, although in a subgroup analysis, it was pre-specified subgroup analysis, there was a benefit in dual antiplatelet therapy in patients with symptomatic atherosclerosis, and did not specify what symptomatic meant. And in a surgical trial, they looked at propensity match analysis observational study among patients that undergoing endovascular intervention, and there was a significant decrease in adverse events in patients that took dual antiplatelet therapy. So you get this mixed signal between older trials and newer trials, and I suspect that it's probably related to the patient population. So remember that, patient population, because I think that's going to be very important in the second and the third talk. The CASPER trial is a trial that studied dual antiplatelet therapy versus aspirin monotherapy among patients undergoing below-the-knee surgical bypass. And again, they looked at endpoints of death, major amputation, graft occlusion. And in the pre-specified subgroup analysis, there was a significant benefit in dual antiplatelet therapy in patients with prosthetic grafts. Now again, this is interesting. This is different from clinical practice, because I know a lot of patients that are on dual antiplatelet therapy that have vein graft, bypass graft, for example. And in a similar trial, the CAMPER trial tested dual antiplatelet therapy versus aspirin monotherapy in patients undergoing infrainguinal endovascular therapy, and this study was never completed because of poor enrollment. And I'm highlighting the fact that physicians would not randomize patients to aspirin alone. The reason I'm highlighting that, because I think it's going to be relevant when we talk about some of the landmark trials, COMPASS and Voyager. The Aspire trial, we're awaiting the results of this trial. It looked at dual antiplatelet therapy. Actually finished enrollment in June of 2018. So it's going to be interesting to look at dual antiplatelet therapy in patients that underwent endovascular revascularization for peripheral vascular disease. Now, the Euclid trial looked at comparing Ticagrelor versus Clopidogrel between both groups, and in reality, it was not a significant difference between both groups with peripheral vascular disease. I don't think the study was powered enough to look at subgroups. 5% of those patients, and I think it's the next slide it's going to show, 5% of the patients had critical limb ischemia. And one of the publications was to highlighted the poor outcome of these CLI patients, but the study was not powered enough to look at the difference in outcomes between patients receiving Ticagrelor versus Clopidogrel, and they have critical limb ischemia. Nonetheless, Euclid showed that there's no significant advantage to the use of Ticagrelor versus Clopidogrel in this patient population. All right, so I'm not going to talk about COMPASS because I know Dr. Neville is going to go through it and discuss it, but basically, COMPASS looked at patients with stable cardiovascular disease, coronary artery disease, and PAD, and I think Dr. Neville is going to dive more into this, and I would love to see his take No, I would love to see his take on it and his interpretation of the data. But I think what I want to say about COMPASS is it really, again, gave us that glimpse of hope that, well, at least now I can do something about my patients that have peripheral vascular disease or coronary artery disease. But I need to find out what's the balance? Where is that nice space where I don't outweigh the benefit with the increased risk of bleeding? So I'll be interested to. I'm setting up Dr. Neville for questions from you guys. So I'll be interested on his take on that. And this is what I was referring to in terms of primary outcomes with Ticagrelor versus Clopidogrel. This is a Euclid trial. Again, about 60 to 65%, and this is a relatively recent trial, right? So about 60 to 65% of patients were on aspirin monotherapy, and it was disappointing to a lot of us in the peripheral universe because the thought process that if you have a more potent antiplatelet therapy that you will see some benefit for those patients. I still would say that in a subset of patients, i.e. CLI patients that have a high risk of adverse events, there might be some benefit, but obviously, unfortunately, we're not able to show this. And if you look at the 5% of the patients that were enrolled in the Euclid trial and they have CLI therapy, if you ever had doubt about the poor outcomes of these CLI patients, you can see the Kaplan-Meier curve. In patients that have CLI therapy, their outcomes are significantly worse than patients that have stable, quote-unquote, peripheral vascular disease or coronary artery disease for those patients. Just disclaimer, myself and Dr. Mustafa Dr. Mustafa is one of the PIs and one of the sub-Is on the Voyager trial. The Voyager trial is looking at the use of Rivaroxaban plus aspirin in patients that underwent revascularization for peripheral vascular disease. And the revascularization can be surgical, can be endovascular. And it's a multi-center international trial with Dr. Hyatt leading the efforts in that trial. And it was an interesting experience for us because I was one of the physicians that said, I think this should be a great trial to enroll patients in. But I think I'm going to share with you, it was very difficult to enroll patients in the United States. And the reason being, we found that physicians have a really hard time not keeping the patients on dual antiplatelet therapy. Despite the evidence that I shared with you that dual antiplatelet therapy is not necessarily a slam dunk, it's not clear that there's great benefit for those patients. What I did not also add in there, like a lot of the trials for stenting in superficial femoral artery or popliteal artery mandated, these patients to be on dual antiplatelet therapy anywhere from 3 months to 6 months, depending on the trial that you look at. But interestingly, the guidelines did not necessarily mandate for you to be on dual antiplatelet therapy. Add to that if you're a cardiologist, a lot of our patients have what I call cross disease. So if you're a patient that have coronary artery disease and you have recent stenting within the coronaries, it was very difficult to remove the patient off of dual antiplatelet therapy. So we had a hard time increasing the enrollment in the United States. It was very interesting. But on the other hand, in other countries, South America, interestingly, and East Europe, they were doing a phenomenal job enrolling patients. So this was a very interesting phenomenon. I don't know if Dr. Walker, were you involved in Voyager? Dr. Neville, were you involved in Voyager? No. Yeah, it was a very interesting experience. That in the United States, we had a very difficult time enrolling. Canada was doing a phenomenal job was embarrassing every time you're on the phone call for the U.S. team. All right, so I'm gonna stop here, and I'm gonna turn it over to Dr. Neville.
Well, thank you very much. It's a pleasure to be here, and I appreciate everybody showing up. You know, it's an interesting topic, and I applaud the organizers and industry for supporting this topic. So, as a vascular surgeon in the past, I always knew what was right for my patients, and I gave them what I knew was right. When you start looking into the literature in terms of vascular surgical procedures and anticoagulant and antiplatelet therapy after vascular surgery or in our vascular surgical population, the data doesn't give you a lot of guidance. There's a Dutch study that shows we should give everybody Coumadin, even our vein grafts. There's a VA cooperative trial that shows everybody should have aspirin, including our vein grafts. When you start looking at prosthetic grafts and arterial stenting, it gets even more muddied. So in my mind, it's always been an area that's not had a lot of data in terms of vascular surgery. So then I make the move out into Northern Virginia, and now we're managing a healthcare system and the vascular health across a population. And that's when I really started actually getting interested in this. And I must say, in all disclosure, these slides were made with Dr. Paul Goebel, who was participating in the COMPASS trial. Paul is a cardiologist and an expert in coagulation, and actually one of the leading platelet experts in platelet function in the world. So I really, once you start considering population health, this is when I think these kind of issues really come to play. I mean, is it better to make sure that all the patients in our systems that have CLI are on statins, or is it better that I dilate one tibial artery? I would argue that this may have more impact than some of the procedural things that we do. So again, I would like to just credit Dr. Goebel with a lot of these slides. So I'm not going to explain the coagulation pathway to you. I probably wouldn't be able to. But we know that one key thing is platelet aggregation. And so after vessel injury or stress on the arterial wall, thromboxane A2 is initiated and stimulated, and we get platelet aggregation. That's where antiplatelet and dual antiplatelet therapy comes into play. Then you have the anticoagulation cascade, whether it's intrinsic or extrinsic. It ends up by stimulating thrombin, which actually converts fibrinogen into fibrin, and it's these fibrin strands with platelet aggregation that forms clot. So we can attack these coagulation cascades in many ways. In the past, we've always given people aspirin. I gave all my vein grafts aspirin. I gave all my prosthetic grafts anticoagulation. And if I didn't do something to them, I sent them to Dr. Walker for the appropriate thing. But now I think when we're really truly concerned about the vascular health of these patients, and we're getting all these additional options, it behooves us to take great care, which I know everyone in this audience already does. But individual variability is quite amazing. So people have different thrombin generating capacities. They have different response to the thrombin and antithrombotic agents, and different response to platelet agents. Dr. Goebel, who I work with in the ANOVA system, we have one of the few places that we have an on-site lab which can determine Plavix resistance. And you'd be amazed how many people are resistant to Plavix. I would argue it's at least, I don't have hard data. We're looking at this currently, and I hope to come out with some data in this regard soon, but I would say it's up to a third of our patients are Plavix resistant. And it's actually fascinating. It seems to me, just anecdotally, that it tends to occur in the patients in whom the bypasses fail. I'm blaming the Plavix resistance and not my bypass. But it's really amazing. So I think we've got to start looking this more individually and more comprehensively to really treat the vascular health of our patients, because we all know that if you have somebody with CLI, about 25% of them, 1 year after therapy, will have their limb and be healthy. So we've got to impact this. 75% will either have passed away or lost their leg or still have their CLI symptoms. This is not very good results 1 year out. And I think that in large measure speaks to some of these medical antiplatelet, anticoagulant issues. This is again from Dr. Goebel, and you all probably know this literature much better than I. It's from the cardiology literature. Just a accumulation of some of the meta-analyses which really show that aspirin and dual antiplatelet therapy, there certainly is a difference, but you buy off a slightly increased risk for bleeding. And if you come up with a net benefit, it's difficult to demonstrate that. So we do know that, but there is the importance of the thrombin pathway, separate from antiplatelet therapy. And when you compare the thrombin pathway inhibition to dual antiplatelet therapy in arterial thrombosis, that still remains somewhat controversial. And again, this is mostly from the coronary literature, showing us that the rationale for these thrombin agents are to prevent de novo thrombus and to prevent embolization or intracardiac mural thrombus. And there is a thrombin pathway inhibition, which obviously is coming to the fore, and there are many medications that are involved and engaged in this. So what about the COMPASS trial? Well, Dr. Goebel is very proud of the trial and proud that he participated, and that's comparing Rivaroxaban for the prevention of major cardiovascular events, and they looked at both coronary patients and peripheral arterial patients. You all know the incidence of cardiovascular disease around the world, and aspirin, as we just heard very nicely in the prior talk, is moderately effective for any long-term medical use. And again, the warfarin trials have also been inconclusive with my review. You've already seen this slide, and this is basically the construction of the trial. They compared aspirin to Rivaroxaban on a twice-a-day dose to a slightly reduced dose of Rivaroxaban and the addition of aspirin, and then looked to see whether it actually prevented cardiovascular events in those patients with coronary disease and symptomatic peripheral arterial disease. You've seen this slide as well, and I sort of circled what I thought were the high points. And where you really compare Rivaroxaban and aspirin versus aspirin alone, there did seem to be a significant reduction in cardiovascular death, stroke, and MI. There was also a reduction significantly in stroke as a primary endpoint comparing anticoagulant with Rivaroxaban and aspirin versus aspirin alone. And you can see the slide in the upper right-hand corner, which sort of demonstrates this data, which I thought was fairly compelling. However, you do buy off higher incidence of bleeding. There's no question about that. There's a higher incidence of major bleeding with the dual therapy, anticoagulant therapy and antiplatelet therapy versus aspirin alone. So you must take that into consideration. You've seen this slide as well briefly, and it does show that when you combine the benefits with this bleeding risk, you still come up with a net clinical benefit with the dual therapy, with a reduction in cardiovascular death, reduction in stroke, reduction in myocardial infarction, but there is an increased incidence of significant bleeding. But the part that was most intriguing to me is it seems like the population which was most at benefit from this approach were the patients with significant peripheral arterial disease. So they, as a subset, looked at those patients who had had a peripheral arterial revascularization, some type of amputation, claudication with a reduced ABI, or previous carotid revascularization or carotid stenosis greater than 50%, or the combination of symptomatic coronary disease and a decreased ABI. So focusing in on the patients with significant peripheral arterial disease. And you can see the breakdown in terms of number of patients who had these different subgroups, and they actually had a fairly high number of patients with symptomatic lower extremity PAD. Interestingly, when you look at the breakdown of the data, the event rate with just the patients with peripheral arterial disease, there was difficult to show significant benefit based purely on primary outcomes. But when you looked at the limb outcomes, there was a significant reduction in major amputation and a significant reduction in limb events, actually, comparing Rivaroxaban and aspirin with aspirin alone in the peripheral arterial disease population. So again, if you plot that out on a graph, there's a significant reduction in amputation or adverse limb event with this combination therapy where you combine antiplatelet therapy with factor Xa inhibition. But again, there were some bleeding, an increase in some bleeding episodes with this therapy, and you must take that into consideration. But again, there's a net clinical benefit for your patients with peripheral arterial disease, especially with those with severe symptomatic PAD, in terms of this combination therapy, despite this slight increase in bleeding. So as my final slide, this sort of is a compilation of the endpoints involved in the COMPASS trial. You can see it benefits patients with overall PAD, with symptomatic PAD in the lower extremity, and interesting also with carotid artery disease. So as I evaluate this for the vascular health of my patients, I think this is fairly compelling data. Certainly deserves further investigation. I think we need to consider these type of medical therapies across the system, certainly for our patients who have had an intervention and those in whom we're just interested about their overall vascular and cardiovascular health. Thank you very much.
So let's get a little bit more granular and look at who indeed benefits the most from this. Obviously, someone with a bleeding diathesis is not the kind of case that you wish to use this, but there are many people in whom we should look at who benefits. But first, let's just start. We have a lot of atherosclerotic disease in this country. And the numbers historically quoted, I may argue with some of these numbers, and in fact I probably will because I can't help myself. But it's stated that 16.5 million people in the U.S. have coronary heart disease, and more than 1/4 of these will go on to have recurrent myocardial infarctions. Cerebrovascular disease, we have 7.2 million adults with all types of stroke, and nearly 1/4 of these people have recurrent strokes. And there are 4.6 million stroke survivors presently disabled in the United States. The argument I have is with this next number. It is a historically quoted number from some of the work of Cricky and others in the past that we have 8.5 million Americans with peripheral arterial disease. Mary Yost, in her most recent publication, would suggest that number is in excess of 20 million. So that number is somewhere in between. We don't know that for sure. But it's really important to understand that within 5 years, up to 80% of people who have a diminished ABI will have some leg pain with exertion. 20% will have a non-fatal myocardial infarction or stroke, and up to 30% will die. Or, put another way, as I frequently put it, really sick legs are rarely attached to real healthy people. That's just common sense. Now, all of these are not created equal. If we look at asymptomatic peripheral arterial disease, we really have a lot of time typically to deal with these patients. Over a 5-year period, really very few of them have worsening claudication, only about 1 in 5. But what we must realize and do a better job with nationally is that somewhere between 15 and 20% of these people will die. And they will die of either myocardial infarction or stroke as the overwhelming causes. So a sick leg is rarely attached to a healthy person. Now, if we have someone who already does have symptoms, they have claudication, again, over 5 years, only about 10% of those will progress on to have critical limb ischemia. But up to 3.3% of those will have an amputation. And once again, about 15% of those will die. And this is a conservative estimate based on a compilation of data. Now, what about critical limb ischemia? Critical limb ischemia is something different. It's a more aggressive manifestation of peripheral arterial disease. So ischemic rest pain, ischemic ulceration, or gangrenous changes. All of a sudden, we don't have nearly the same amount of time because at 1 year, 30%, if nothing has been done to change the course of therapy, will have a major amputation. And 25% of that group die. And then finally, perhaps the strongest manifestation, the worst manifestation of peripheral arterial disease, acute limb ischemia, at 30 days, this is a true medical emergency, up to 30% of people in our country have had an amputation, and up to 1/4 of those are dead. So this is really very important disease where the outcomes are measured above and beyond just the limbs. Now, all of us are at this meeting because we have a devotion to try to stop amputation. Amputation is bad. If we can avoid amputation, we should. And this slide, published in the American Heart Journal, we can see shows that if you indeed have an amputation, you have a much, much higher rate of all-cause mortality. In fact, it's nearly doubled. Now, as we search out the manifestations of atherosclerotic disease, and we look at coronary artery disease, we have stable coronary disease, and then we have unstable coronary disease, the unstable angina, the acute coronary syndromes. What is changing in this situation? It's thrombus. That's been well demonstrated in the past by studies where people actually went in and looked with angioscopes and they showed thrombus. What about cerebrovascular disease? Once again, it's stable. What makes it unstable, bits of clot or plaque or clot from the heart embolizing to the brain. And then we have unstable symptoms. And then finally, peripheral arterial disease. We have asymptomatic or we have very stable symptomatic disease. And then all of a sudden we have superimposed clot on critical lesions, and we go to critical limb ischemia. So every one of these syndromes where we have less time to intervene, where the risk goes up, really have a strong thrombotic component. Now, we have for many years tried to mitigate against these thrombotic events. You've heard us talking about using aspirin. Why do we do that? Well, aspirin blocks the thromboxane-mediated pathway of platelet aggregation and ultimately thrombosis. We also utilize drugs which affect the ADP receptor. It's drugs like Plavix, Prasugrel, Brilantin. Drugs such as that modify this. Once again, they modify platelet aggregation. We have a newer agent, a POR1 receptor blocker called Rivaroxaban, Zontivity, and it blocks activation of the POR1 receptor of the platelet, which again is thrombin mediated. But suffice it to say, of all those things which can make platelets activate and ultimately result in thrombus, the single strongest stimulant is thrombin. Thrombin is a strong stimulant to platelet aggregation, and historically, we've not always addressed that. So I'm not surprised at all by some of the results that were shown in the COMPASS trial, because thrombin is the single strongest mediator of platelet activity and platelet thrombosis. So thrombin becomes very important. Not only does it stimulate platelets, but it has a lot of other factors. Vascular inflammation occurs with this, leading to lesion progression. In fact, many believe that the calcium which we see in arteries is a function of some clot in the healing process, which doesn't result in total occlusion, nonetheless allows incorporation of calcium. It results in endothelial dysfunction, which can be profoundly important in terms of spasm. And of course, it can lead to ischemia and ultimately necrosis of tissue. Now, who should we be most worried about? Well, I think there are several subgroups that we must really have a red light blinking in our minds when we see them. So if we look at the overall population of patients and we look at disease and we look at those specifically who have diabetes, we can see from the REACH registry that if you've had a non-fatal myocardial infarction or a non-fatal stroke, or you've had prior issues with cardiovascular death, if you have cardiovascular death, or looking at the sum total of cardiovascular death, non-fatal MI, or non-fatal stroke, look at what happens in the diabetic cohort. Diabetics, simply by the basis that they're diabetic, have statistically higher risk of developing each of these outcomes. So diabetics represent one group of patients who are at substantially greater risk. Whom else? Well, what about polyvascular disease? If we look, shown here in dark blue, of those patients who have a single vascular bed involved versus those in light blue who have multiple vascular beds, carotids, peripherals, heart. The more beds we have involved, again, the worse the prognosis. And you can see all of these are statistically highly significant. And in fact, compared with coronary disease or carotid vascular disease patients, patients with PAD had the highest rate of progressing to atherosclerosis involving other cardiovascular beds. What about looking at this on a long-term basis, looking at the cumulative incidence of cardiovascular death MI, or stroke? Well, if you have risk factors only, that risk is 9.1%. If you have stable ischemic disease with no prior ischemic events, that risk escalates. It becomes 12.2%. If you have stable atherosclerosis, but you've had a prior ischemic event, the risk goes up yet again to 18.3%. But in a 3-year follow-up, those patients who had any coronary artery disease, these risks at 3 years included 29.7% with coronary disease with any form of carotid disease, 28.1%. But look at the patients who have peripheral arterial disease, the focus of why we are here. Peripheral arterial disease patients have an incredibly high risk of having myocardial infarction, stroke, vascular death, etc. And we have unfortunately not always linked the incidence of peripheral disease and a diminished distal pulse to life and death. We focus maniacally on limb salvage, and I think we have to focus broader. We have to focus on patient survival. This is a very, very important message in terms of why all of us must embrace peripheral arterial disease and make sure that we find it. With that, I'm happy to answer and to address any questions you may have. I will ask, because this session is being recorded, that you would come to a microphone to address your questions if you have one. I see that Emily's walking around with a microphone. And
this is a phenomenal discussion, Craig. Thank you for going over it. I like the PAD component that you showed, although we focus primarily on the heart sometimes when we're using some form of platelet inhibition, like you mentioned with aspirin and ADP receptor inhibition. So when you're talking about anti-10A, like you just described right now, so for us as CLI specialists or PAD specialists, when do you think is a good time to start it? Can you simplify it for us? You know, is it fair to say at this point, post intervention, we usually use, like, for instance, aspirin and some form of ADP inhibitor? Mm-hmm. Is it reasonable to add anti-10A for high-risk patients like CLI patients?
First, let me ask the panelists. What are your thoughts, Richard?
So I struggle with this data, and I was actually going to ask that same question. I think, Judd, what I've done is in my post-revascularization patients, I've gotten more aggressive with adding an anticoagulant. That's easy for me to do. I'm doing surgical procedures. I would like to anticoagulate them for graft function anyway. So I've gotten much more aggressive with anticoagulating my prosthetic bypass grafts and even my endovascular reconstructions. But along your lines, and I'd like to hear the other opinions, what I struggle with in assimilating this data is, let's say I have somebody that comes in with claudication or symptomatic PAD. Do I need to put them on Xarelto?
Fadi?
Yeah, I mean, for us, I hate to say cardiologists, but we have a lot of data.
But you said it, though. Why don't you just take it back? Correct it.
Yeah, it's recorded.
Okay.
But we have data to clearly document that bleeding is bad, transfusion is worse. And we actually struggle quite a bit because we have a large, in the CLI population by default, you have a lot of patients with chronic kidney disease, end-stage renal disease. You have patients with lower body weights and high body weights, high BMIs. And those four things are associated with higher risk of bleeding. So we actually struggle quite a bit which patient population we're going to put that on. And I'm personally intrigued, and I'm hoping that the company or the investigators will put a sub-analysis or a follow-up paper creating sort of a score, bleeding score, or identifying the high-risk patients that can undergo bleeding. So offer us some guidance to which patients we can at least give them a measure. So we have this HAS-led score that we use for AFib patients to determine which patients are at a higher risk of bleeding. And I think there's enough patients in the COMPASS trial, for example, to predict which patients are at a high risk of bleeding.
So first I want to comment on the COMPASS trial. So in this trial, the dosage used is not the dosage that we presently have available. Very important. I don't want you to extrapolate this data and say, okay, I'm going to use what the doses we have. This was 2.5 milligrams twice a day, which is a minuscule dose as compared to the standard doses that we've had placed. Very important. We don't want anyone to leave here and say, okay, I'm going to use what I've got on the shelf right now, which is, much higher dosage, and expect the same risk profile. That would be an error. Secondly, I do think that there are certain patients that we clearly understand should be on this from the get-go. People who've had ultra-complex interventions, in my opinion, where we have slightly diminished flow or where we're concerned about runoff, we know intuitively those patients have a much higher rate of abrupt thrombosis, and I think care there makes sense. Diabetics. If we look at the earlier trials, diabetics tend to always benefit the most from additional anticoagulant effect, and this trial proved that as well, and I would argue that maybe that's even more manifest in the peripheral vascular group. So first thing I think we need is the right dosage, which we don't have yet, but which I suspect will become available in the future. And then I think diabetics, polyvascular patients, people who've had several events, and perhaps very complex interventions with diminished flow, I think they will become the obvious sources where I'm going to use this. And I'm going to use it if there's not a clear bleeding diathesis. I'm going to use it. Now, my real question is, should the second agent be aspirin or should it be clopidogrel? Because in the one trial that compared the two, clopidogrel was more effective and actually had less bleeding than clopidogrel had less bleeding than the aspirin in that trial. Aspirin has a direct erosive effect on the stomach. That's beyond the course of a meeting tonight, but they're just questions that I think we should all think about as we move forward.
When you're talking about clopidogrel and its indications, so it's nowadays you have to stay on indication in terms of utilization, and unfortunately, some of the stronger anti-ADP inhibitors are not indicated for long-term use, unfortunately.
That's right.
So the triple therapy question I want to go back to is actually something that we find ourselves having to, not wanting to, having to. So we have not seen any significant problems yet, but I don't think that's something that is fair to say that this is how it's going to be all the time. I really worry about it, and we do it, and we watch those patients so closely. We always use 81 milligram of aspirin. We use clopidogrel instead of Ticagrelor or anything, or Prognosis is not actually approved for that, but we use clopidogrel and then watch it, and then we use the anti-TNA along with this, who have, actually a fair bunch of patients on triple therapy, and those patients keep us awake at night sometimes worrying about them. So I wonder, Rich, I like what you said, in some of your graphs that you're worried about, you use triple therapy. Is that what you said, right?
That's right.
Triple therapy. So we've seen actually benefits of it, but it's really scary for us.
But there's not a lot of data to guide us in that regard.
So the question becomes to the company, because we know in Voyager that we allow patients to be on dual antiplatelet therapy while being randomized to Rivaroxaban for a short period of time, and then you can take those patients off. And the question becomes is, do we have enough patients? Probably going to be mostly U.S. patients, because that was the hardest group of patients.
Yeah.
Do we have enough patients to look at the outcomes of those patients within 30 days or within 3 months? That's yet to be seen, because you had to remember how much of a hard time we had enrolling patients in Voyager. Because
we're having a hard time enrolling, but and this is what happens when you have a difficult subset of patients that need something very badly, and those patients are not available in a large number. But like you said, in Voyager, the triple therapy, we're using it, but we're using it for a short period of time. And I think that's the wrong thing to do, and you do too. We've talked about it. We need something for long term, but no one is willing to take that risk. And, Rich, once you have that graft in, it's in. And once we do that complex intervention, and the recent patients that you did, for instance, right? I mean, those patients need some form of protection. And in Voyager, Fadi and I have been heavily involved with this trial. It's really promising, and it's nice to see that there's, additional therapy for this really sick patients. But I'm actually, just like you guys, wondering, what is the right time, and when do you take aspirin or Plavix off? Because when you look at the mechanism that you showed right now, earlier, all of us know that, right? And you question yourself, do I do ADP inhibitor removal, or do you do COX inhibitor removal, which,
Sure. And, we talk about risk of bleeding, but we often don't even think about the other risks, fall risk. If you fall and bleed, all these other things that matter substantially. And so, we have to work through those. And I think obviously time will help us with that. But I would say that I think the COMPASS trial has been a very encouraging trial.
It is. And what I like about it the most is actually the fact, it's anti-10A, so kind of like helps you so much with both intrinsic and extrinsic pathways. So this is where, the value comes in, but then this is also where the risk comes in. And I think
But Jihad, I would argue that the kind of patient you described, with the kind of interventions you do and the bypasses I do and those people were throwing the kitchen sink at them anyway. It's almost easier for me. And I'm going to push Craig on this. So what I'd like to know is if you've got somebody that comes into your office with diabetes, they had a carotid endarterectomy 5 years ago, and they've got claudication, and they're on aspirin. Are they walking out of your office on an anticoagulant?
Not a chance. Not a chance. Craig and Jihad, I'm glad you brought that.
I mean, the other patients are easy. We're throwing everything at them. If I'm doing a distal revascularization inframoleolar, I'm putting them on antiplatelet agents and anything they can tolerate. But what about does this give us enough data to add anticoagulant therapy to our standard vascular health regimen?
Well, let's hear from
Yes, and I think that's a very important point. And Craig, I was very glad to see you bring up that 40.8% event rate with PAD and everything else. And there may be a day that we have them on one form of triple therapy and another day that we have followed that with triple antiplatelet therapy. And no one really talks about that, but you brought it up. Thrombin is the most potent aggregator of platelets, period. Yet you see very few cardiologists, very few peripheral vascular interventionalists inhibit PAR1. Rivaroxaban was originally produced by Merck, and they gave up on it. And a company in Canada bought it, and we were able to get it for my patient population through them until now. And now they are either going to drop production until someone else picks it up. But if you look at what I call TAP, triple antiplatelet therapy, with ADB inhibition and PAR1 inhibition and standard aspirin in the doses of 81 milligrams, the event rate reduction in that trial with Rivaroxaban went from a minimum of 17% to a maximum of 22% additional event reduction on top of aspirin and Plavix. To me, that is such a huge number that it justifies what I do. I keep those patients on triple antiplatelet therapy along with gastroprophylaxis for life, because platelet aggregation and platelet adhesion are a precursor to the progression of disease, whether it creates an event or not. So this is something that I think that really has to be considered, and my answer is triple antiplatelet therapy for life unless there's a good reason not to. And I was really glad that you brought up that, and 99% of cardiologists don't talk about this.
So I'm curious, how many people have you had to back off on that regimen because of bleeding or other problems? Have you had? Very few.
Well, it's interesting how we're flying blind, and we have no data. And it's all because we think, gee, we sit around in these meetings, but we have no data. Now, there's an opportunity, for venous stents, we're dropping NOACs and Plavix all the time. Maybe in a VIS registry, if you look at those people, maybe we can go back and say, what's the safety of large dose anticoagulation plus Plavix? That's out there right now, and everybody who's doing venous stenting is doing that right now, but no one's looking at it. And the other question is, are we using the right NOAC? Okay, because there are some differences in half-life and safety between one and the other. So is anyone going back and looking, say, at Eliquis at a very small dose or something? Is that being done at all? I'm sure there's interest in the companies, but I don't know. Are there trials out there?
Yeah, great question. We don't have any data from anything else showing. So first off, the data was around this drug, but I do want to also set the mindset correct, because the drug dose used here was not the standard drug dose. So if you're used to using Xarelto, if you're used to using Eliquis, if you're used to using these other drugs in a given dose, understand this is a tiny fraction of the dose studied in the COMPASS trial that was studied in those others. So historically, when people have done triple therapy and have included a 10A inhibitor, they're doing it with high dose of those agents, not low dose. And so I think it's a very, very important thing for us to just realize this is comparing apples and oranges if we look at that. And that's very important. I want to make sure that specifically in the COMPASS trial, can't emphasize this enough, this was not full dose. This was not even what we call low dose. This is a fraction of what we historically called low dose, which is interesting that did indeed show highly statistically significant difference in bleeding diatheses. Yes?
Hi, I'm Brad Lynn, one of the podiatry residents from JFK Medical Center in West Palm Beach, Florida. I'm here with Regina Fiacco, my co-resident. From a surgical standpoint, I wanted to get a recommendation from you guys on holding anticoagulants. I know you talked about bleeding is bad and transfusion is worse. Digital amputation is not usually a problem, but something with like a transmetatarsal amputation, these patients have been on anticoagulation therapy for a long time. What are your recommendations on holding anticoagulation for that period of time for the surgery?
Richard, you do more of that than us.
Yeah, boy, we struggle with that. And congratulations on introducing your co-resident. That doesn't happen too often. Very good. But no, we struggle with this all the time, to the point where we actually had to make what we called an preoperative onboarding sheet, so that everyone agrees what's going to be stopped and what's going to be continued, because it's often the cardiologists that say we can't stop the Plavix, we can stop the Plavix, we can't stop the anticoagulation, we can transition them, we can just stop it. And, he said, she said, it gets very confusing. So we actually came up with an onboarding form for anybody on Plavix, not aspirin, but Plavix and an anticoagulant, where I've got to sign it, and whoever the physician, cardiologist, or whoever has them on those other medications has to sign it. That being said, I do try to stop Plavix if I can for certain procedures. Carotid endarterectomy, although the data doesn't support that you can do carotid endarterectomy safely. Dr. Hayes is nodding. I take them off. I just don't want to, unless it's a recently deployed drug-eluting stent. If they're on it just because they're on it, I'm taking them off Plavix. Because I'm a chicken. I hate hematomas. I hate hematomas. Yeah, there you go. Okay. You could do that too. All right. But if I'm doing an endarterectomy, I do take them off Plavix. It depends on the procedure. For the legs, I leave them on most anything. The one thing I will caution you on, I don't know what your guys' experience is Brilinta. If you've ever operated on somebody on Brilinta, oh my goodness. Yeah, I learned that the hard way. So be very careful with Brilinta.
Brilinta, I think, is
much more potent.
Yeah, standard recommendations for full dose of antiplatelets historically, if you really wanted to reverse them, were for 2 days for most, for Pradaxa, 2 days for Xarelto, and 1 day for Eliquis. That's historically been what was full dose. We have no data right now on this lower dose, how long. The antiplatelets, I think there's pretty pretty good opinion, somewhere between 5 and 7 days, the antiplatelet effect is gone.
But on these revascularized legs, would holding them be detrimental for the procedure that was previously done?
Usually not detrimental for what we've done, but it may be detrimental to their coronary stent. So, again, for the limbs, we usually don't stop.
Do you guys notice a difference if you stop it for a day or two?
Yeah.
Because I mean,
As per what Dr. Walker just said in terms of timing.
no,
No, not
I mean
so much.
for antiplatelet therapy, no, but
No.
we get always asked that question. You know,
No. Have they really? Yeah.
They'll operate as long as they've not had the bolus within 40 doses, low.
Yeah.
But
You're talking about Plavix.
Yeah.
Yeah.
5.4 days for platelet aggregation normalized after cessation.
Yeah.
7
For aspirin.
Yeah.
Yeah.
So to get back to your question that we don't have full data there, I do think it matters from patient to patient. You've done an intervention, you've got some flow. Some flow is, there are cases where there's tenuous flow, and there's some cases where there's less tenuous flow, some cases where you're really worried about outflow, and I do think it matters. And I think you have to just simply weigh in your mind's eye right now. I don't think we have a real number to give you, but I think you have to weigh the risk. How apt are they to thrombose versus how much of a bleeding risk are you? And you're going to be the guy best apt to.
But that's why
deal with
communication is
that.
important too, and why we have that on board. So make sure everybody talked, so I know what I did and why I want them on what I want them on. You know what you're going to do. We've got to figure it out together.
and you know, not to.
It's also important to note that endothelialization rates are different from different coronary arteries.
Right. And not to minimize, not to extrapolate, but we know from bypass surgery that patients that were operated on with aspirin and Plavix had high risk of bleeding, but no impact on mortality. Right? I mean, at least for cure CABG, that's they looked at that. That's been established. And actually, patients that remained on Plavix did better from an ischemic standpoint. Again, they had high risk of bleeding, but they did better from an ischemic standpoint post surgery. So just.
Any other questions? Specifically, I want to try to drive us back towards speaking, though, about 10As, because I think this is a whole new field, and it's exciting. The data coming out is really exciting data, and we don't yet have the drug in the dose that we wanted. It's something we're going to wait a little bit for. This data is exciting data as to where we head. Yes?
So as we use this lower dose, I guess a question for a surgeon, I'm a vascular surgeon in Seattle, how anticoagulated are these patients? In other words, I mean, if a patient, can we operate on one of them with this? If a patient shows up with an acute emergency, are these small doses really truly therapeutically anticoagulating the patient?
That's a great question.
It's a great question. I don't have that answer.
So is there a way we can, none of us are hematologists, but is there a way we can measure that?
Yeah, no, to my knowledge, there's not a great way to tell that. Certainly not at least in the average lab. There are some sophisticated assays that can assess antithrombosis. But I will also tell you, in this trial, a higher dosage was assessed, and there was no additional efficacy at the higher dose. That's why the lower dose was chosen. So I'm not sure from the purpose of preventing these events, at least in the COMPASS trial, that they thought that the extra potential risk of bleeding was worth the risk of the higher dose.
I'm Dr. Smith. I'm from Houston, Texas, one of our physicians. My question to the panel is this. What about those patients? You want to revascularize these patients, however these patients have severe comorbidities, they say, for instance, renal failure. I mean, how do you deal with those patients? Because I've had a patient, despite being on that low dose, die. Okay, so my question is, how would you deal with a situation like that? Should you test the patient first? Do we have any testers in place to say, okay, do I want to do this procedure or not?
Okay, I think you're asking two questions as best I can tell. Would I do the procedure in a patient, in a peripheral procedure in a patient with renal dysfunction? I do those all the time. And I use CO2 or I use ultrasound guidance. And we have superb CO2 systems now that for some types of disease actually image better than iodinated contrast. Now, if you're asking if they have severely impaired renal function, does that affect how I may wish to anticoagulate them? That's a different question. And that does concern me because there's a risk of hemorrhagic pericarditis, or risk of other things that go on, and it depends upon the amount of renal dysfunction. Are they dialysis dependent or not? Are they still making urine? All of those things would enter that. But we have no data that I have seen yet. I read the COMPASS trial. I have no data to be able to guide, and I don't think there's any data guiding how we would treat, how we would change the anticoagulant regimen in that group of patients. I don't think that data exists right now.
You know, we know from the PRIME registry, 50% of our patients had a GFR less than 60. So by default, whenever you're dealing with CLI patients, you're dealing with patients with chronic kidney disease, but at least stage 3 chronic kidney disease. Yeah. And to Dr. Walker's point, you know, including those, that's why I asked the question about high risk of bleeding for a lot of those patients. Sure. Including these modalities that decrease patient exposure to contrast-induced nephropathy, you will be able to safely treat those patients. You know, what I tell my patients, it's not about right or wrong. It's about weighing the good versus the bad. You know, I memorize this statement so much because I always say it with the patients. Because I'm not doing anything wrong. I'm not doing anything completely right. We're going to sit down here and we're going to weigh the good versus the bad. I know if you're a chronic kidney disease patient, stage 3, and if you develop contrast-induced nephropathy, it's a bad thing. But I know if you lose your leg, and all of us know this, but that's a conversation I have with the patient. I know if you end up with an amputation, your chance of mortality is up to 40% or up to 50% within the next 2 years, 25% within the first year. And I have this conversation with the patient because, unfortunately, we cannot undo the damage that's done to the body by the time they walk through the door to us.
But in today's world with CO2 and ultrasound guidance, you can get away without using iodinated contrast, and those do not impair renal function further. But if you're asking the question along the lines of, are those people at increased bleeding risk? Certainly. If they're on dialysis, that answer is yes, where they get uremic pericarditis and other such things.
Yeah, they have platelet dysfunction just
and they have
by their renal
dysfunction by nature of the disease. Right. Any other questions in the audience? You know, I remember as I read the COMPASS trial, I was actually a little bit surprised with the data. I looked at it and I was really impressed by what we saw, and certainly it's encouraging. And I think we're going to learn a lot in ensuing years about how we best treat our patients to lessen their risk of going on to have heart attacks, strokes, or recurrent limb events. And but I certainly applaud Janssen for the effort that you've put into educating people about the risk of thrombosis and for trying to help us figure out how do we best treat these patients. So please, if you could fill out your forms and submit them, we would clearly appreciate that. And if there are no questions from any of you, then perhaps we could adjourn, but not without saying thank you for your interest in treating these patients, and thank you for your time tonight in trying to improve how we treat patients. Did I see a hand go up? One more question. Yes, sir.
Going back to the point that you made about the drugs, Plavix resistance, I mean, even aspirin at high doses, high enough can be thrombotic. The same thing, maybe the anti-10A level, the DOACs, while maybe on a large scale you don't need to follow them, but there's probably a lot of patient-to-patient differences that we don't really know. Did they, in the study, did we look at the BMI, the renal function? Is the patient dehydrated on the day they bled and they were a little bit more were a little more therapeutic than you'd like them to be? Are those things being looked at in terms of really better defining the risk profile of the patient population you're looking at?
They had different parameters within the study. I don't know if those issues have been sub-segmented out enough for me to give you an answer. I read the trial. I don't remember seeing those things sub-segmented out. I don't want to give you a wrong answer. I don't know. I can ask the company to perhaps answer that question if they have access to that data. I don't know. Yes, sir.
Just a comment and suggestion for next year. Both you and Dr. Saab mentioned it, and initially Dr. Saab made a comment that this meeting has been criticized for being just only about opening the arteries, which is not true. I'm suggesting sometime next year we should incorporate the non-mechanical part, very equally important. Tonight we talked mostly about the coagulation cascade and platelets, but I think the most important thing is we should also remember to talk about statin therapy, ACE inhibition. The very first time we come into contact with the patient with PAD, 2 weeks ago, a veteran came to our hospital. His first contact with medicine was a AAA 6.4, and he had that sealed. He also came with very high blood pressure. So the patient now is on aspirin, clopidogrel, high dose statin, and everything else. So I think next year we should somehow incorporate this part and remind people that yes, the treatment the disease is a continuous process, and we need to tackle it from all angles. And that's my suggestion for next year.
I think Jihad wants to address that. Jihad?
Thank you. I can't thank you enough, actually, for raising that point. This is really important topic, and medical therapy is one of the most important foundation for what we do. I can definitely reassure you that next year we'll have that on the agenda. It's already actually in the process. When we started AMP, actually, there wasn't much of data to discuss. Now we have phenomenal data. Medical therapy, whenever we used to give that talk to someone a few years ago, they used to frown on us and say, there's not much to say. But actually, you are spot on, because now there's tremendous amount of data that supports, like you said, for instance, statin therapy and what it does to PAD and CLI in combination. ACE inhibitor, for instance, the benefit of that is significant. So I reviewed the literature, and unfortunately by the time we got here, it was a little bit too late. But you're absolutely spot on, and I want to congratulate you, actually, and you deserve an applause, actually, for that. Please, let's give him an applause for that. Thank you, because you are spot on, and the data showed if you do add statin to a patient with PAD, it does reduce the event rates.
No two ways.
If we'll probably read the same data, you and I. Thank
100% of patients with PAD need a medical intervention.
Yes.
A much smaller percentage need a cath lab intervention or a surgical intervention. But 100%
you're right.
require medical intervention.
Actually, Richard and I were talking about it today. So I wish you had. I'm glad you mentioned it anyway, but Richard and I were talking, and we were saying that we hoping for the future that we would use medical therapy and less invasive procedures, and it looks like hopefully someday we'll get there.
Well, especially as things move more and more towards population health, personalized medicine, and accountable care organizations. Let me tell you, it's going to be quite important. So I think that was a great idea.
Last call for any questions? If not, let's all give a big hand to Janssen for providing support for a meeting like this and for what they've done in this field.